Yeah, thank you. From Monday to 2020 and 2020 to 2010. And I think good glycemic already saved 1 minute. So now next point in diabetes is obesity, and it is a neglected thing for years together. If and it's not a new concept. In 2011, glucocentric approach and adipocentric approach were described, but at that time, the problem was there was controversial results of many anti-obesity medicine was there. We were having very few agent, and we were not having long-term data with that. Otherwise, to treat pathology, the right approach is to treat pathology, and that is very true for most of our type 2 diabetic patients. Because type 1 GDM, yes, we have to be glucocentric, but at the same time, in type 2 diabetes and with severe risk, it is obesity which is playing a role, and which is very nicely described by our own Dr. Professor Yajnik when he was doing this thin fat Indian study, and we all are looking thin, but still we are obese. And that's why the concept of obesity with diabetes, it turns out to be diabesity. And diabesity is nothing but uh, combination of this deadly duo, which is causing almost half of the patients suffering with obesity and diabetes both, and numbers are increasing day by day because of change in our lifestyle. Why obesity matters in diabetology? Because it is common, because it is associated with CVD. My next speaker is going to put emphasis on this part, and that's why we have to treat obesity, because it is modifiable risk factor. That is most important thing, and it is white adipose tissue which is giving rise to multiple other cytokines and inflammatory markers, which increases cardiometabolic syndrome. That is the risk factor, and that is mainly because of glucotoxicity, lipotoxicity, and inflammation, which is secondary to insulin resistance, which leads to change in the translation of mitochondrial pathway, which leads to multiple pathophysiology, which can be described as hypertension, coronary artery disease, hyperlipidemia, and along with that, adiposopathy may leads to osteoarthritis, non-alcoholic steatohepatitis, obstructive sleep apnea, and macro as well as microvascular complication of diabetes also. And there is nothing like sudden heart attack, which we are listening, which we are reading so commonly. It is central adiposity, lack of physical activity, genes, and over the top, this multiple inflammatory markers in form of decrease in adiponectin level, increase in leptin level, RO2 activation, RAS activation, TNF alpha, interleukin 6, and CRP elevation, and increase in the free fatty acid, which leads to metabolic syndrome and CVD. So, what should be our prime goal to treat type 2 diabetes? Yes, glucocentric approach, as it is very important once patient is diabetic. But can we do it before? When patient is pre-diabetic, when patient is obese, it's an upstream approach, upstream intervention, and for that patient has to lose weight. If patient loses weight by 5 to 10%, there is better type 2 diabetes management. Fatty liver improves, PCOS improves, dyslipidemia improves. For reversal, for remission, actually, and for real change in the fatty acid, fatty liver, it should be 10 to 15% of the weight loss, and more than 15% actually leads to type 2 diabetes remission, as well as CV mortality, as well as reducing preserve ejection fraction heart failure. So target of weight loss 15 milligram is new HbA1c target of 7. What we are talking about. So if we are glucocentric, it is less than 7 HbA1c. Similarly, for weight loss, if we can achieve more than 10, and if possibly more than 15%, you can see number of studies with us which has shown excellent diabetes remission or decrease in complication with multiple things. This is continuum. When patient is diabetic or patient develops various complication, it starts before it, when patient is in hyperinsulinic phase. So can we have impact when patient is pre-diabetic? We have diabetes prevention program where lifestyle modification was compared to metformin to compared to placebo, and we found that not even metformin, it is lifestyle modification and persistent weight loss, which has shown excellent benefit of 58% reduction in type 2 diabetes occurrence. Similarly, once patient is diabetic, can we remit it for a while? without medicine or with very few medicine or like insulin sensitizer? Yes, it is also possible. We have look ahead study where it strict intervention in form of diet and exercise was done in comparison to placebo, and you can see there is excellent weight loss. The only problem in look ahead study was it was difficult to maintain, it was difficult to achieve that weight loss for longer period of time because patient starts regaining. Then comes direct study. Direct study was done again with very low carb diet and change in the fat, targeting 15% weight loss. And you can see that with 15 kg or more than 10 kg weight loss, there was excellent ratio of diabetic remission, and that was persistent for 1 to 2 year. That is something excellent and which has shown, which has changed our treatment pathway. And when we are talking about micro and macrovascular complication, we have some data from look ahead study that more than 10% of the weight loss is also reducing CV mortality as well as other complications of diabetes. So our approach should start with obesity before patient develops frank diabetes, and for that we have diet, exercise, behavioral therapy, we have pharmacological therapy, and obviously with morbid obesity it is bariatric surgery. So BMI 25, lifestyle changes is enough. BMI 27, it is you have to consider pharmacotherapy, more than 30 pharmacotherapy, and after that you have to consider bariatric surgery for such type of patient. As far as dietary pointer is concerned, all diet are good ultimately if person restrict total calorie and the calorie deficit is more than 500, then it is helpful, and whatever diet patient is convenient to is patient has to continue for longer period of time. Along with that, lifestyle modification is having restriction because as Lookout study has suggested, over the 2, 3, 4 years, patient starts regaining because patients are not actually maintaining their lifestyle. Many anti-obesity medicine has limited efficacy like phentermine, topiramate, naltrexone, bupropion, and even we have liraglutide, which was having only 5 to 7% of weight loss, and few were withdrawn from the market also. Now we have GLP-1 arrays like semaglutide. We have dual GLP-GIP combination, that is tirzepatide. Even retatrutide is coming. It is in clinical trial. And SGLT2 inhibitor. These are disease-modifying agent rather than an anti-diabetic agent. And with liraglutide, we had good weight loss, but now with sema and tirzepatide, we are aiming for more than 15% of weight loss, which exactly we are looking for. And you can see the data of step 1 to step 8 study with semaglutide, patients are losing more than 10% of body weight loss. 2.4 milligram semaglutide, the higher dose is even better. That is in step 10 trial, which has shown almost 15% of weight loss. Similar data with SURPASS study with tirzepatide, 13% of weight loss, which is fine. And retatrutide, actually we are aiming with 20 to 22 percentage of body weight loss with 50% reduction in liver. So now we have agent to substantiate that, and there is one data of empagliflozin and liraglutide combination which actually reduces CV risk also. Along with that, if patient is morbidly obese, obesity of BMI more than 30 with comorbidity, you can have option of bariatric surgery also. And with bariatric surgery, you can see in comparison to medical therapy, it is having even better result as far as diabetes remission is concerned, and lesser patient were having microvascular complication after this. Except cerebrovascular disease, in all part you can see all cause mortality, heart failure, CAD, atrial fibrillation, and nephropathy was improved after. The risk was improved after bariatric surgery in comparison to patient who opted for medical therapy. There is another data where 90% of the patient were having diabetes remission. These are 21 studies from Asia after bariatric surgery. So weight reduction is very important. And when we are coming across type 2 diabetes, or maybe I say before type 2 diabetes in a pre-diabetic phase, if we target weight, you are going to target HbA1c. And this should be our new target. And for that, recommendations are also now looking for that you should uh, take the agent which causes weight loss if possible and if it is tolerated, and you should prefer to use that obesitogenic agent later in diabetes practice. So I think weight is very important part and we should always focus for that. Thank you.